Thank you all. Today is Friday, March 26th. Good afternoon. Welcome to the Senate Finance Committee. We have 4 bills to be heard today. We're going to start with Senate Bill 876, and Delegate Attar is going to bring Dan Rabbitt from the Behavioral Health Systems of Baltimore. And then we're going to go to 878. That's also Senator Attar. Did I call you delegate the first time?
I'm not sure. I wasn't even paying.
Senator Attar, Health Facility Certified Recovery Residents will be your next bill. So, Senator, you can start.
Thank you, Madam Chair, Mr. Vice Chair, and members. So I'm starting with Senate Bill 876. The two of them kind of go together, but we'll do each one. Okay. So in my district, there are some issues that affect just like one neighborhood here or there, and there are other issues that keep coming up that affect pretty much the entire district. And this recovery residences opening up throughout Baltimore City on all different streets and infiltrating many of our streets is one of the biggest problems that my constituents have been coming to me for many, many, many years. And now we all agree these residences are extremely important. We have them for a reason, they're necessary, and we need them. The problem we're finding is under Maryland state law, these residences don't have to be certified. I can just say, you know what, I want my house to be a recovery residence no matter where it is, whether there's children next door, whether there could be 7 already on my street and I can open another one. And for years we were looking into federal law and to see if we can limit the amount. And unfortunately under federal law, there are protections for facilities like this. And we can't limit the amount of facilities that will be on a street. We can't even limit necessarily if they're around a school, which neighborhoods they're in. So we're taking a little bit of a different approach. And number one is a lot of these residences that are not certified, they don't follow basic proper rules, and they don't follow the basic law. And nobody's checking in on them. Nobody's making sure they are safe facilities. They're facilities in our neighborhoods, but inside of them, they're not even safe for people to be there. So yes, we need these facilities, but we want them to be safe. We want them to be good neighbors, and we want them to keep others safe as well. So I know I've been in touch with, over this last year, I've been working with a lot of my communities in my district to try to come up with solutions, and we've had the Maryland Department of Health at the table trying to come up with solutions. And the last meeting that I was at with them, they had said that they don't even know how many uncertified residences there are, recovery residences there are, because they don't have to register with the state, and the state doesn't have to monitor them. So we don't even necessarily know the number. I could just tell you in my district alone, there are some streets that have 5 or 6 of them on one street. So what this legislation would do is it would require that if you're going to be a recovery residence, you have to be certified in the state of Maryland. And currently, there are, the Maryland Department of Health submitted a letter of information that does say the amount. I think there are about nearly 300 certified ones. My number might be a little bit off. I don't have it right in front of me, but about 300 certified ones. This would say if you are a recovery residence, that's fine, but you need to be certified. So that way we can ensure you are a safe facility and you are a good neighbor. And with that, I would ask for a favorable report.
Senator Dan, you want to testify?
Sure. Good afternoon, Chair Bidle, Vice Chair Hayes, members of the committee. For the record, my name is Dan Rabbitt. I'm the Policy Director at Behavioral Health System Baltimore, BHSB. We are the local behavioral health authority in Baltimore City. And we have seen a lot of the same behavior and circumstances that Senator Attar is talking about. Just to explain recovery residences a little more, they really are a unique aspect of our behavioral health continuum. Most behavioral health programs are accredited by a third party and then are issued a license from the state, from the Behavioral Health Administration. Recovery residences are not traditional treatment. They're housing. They're more of a housing, just a residence than a treatment program. And so they are not issued a license by the state, and there's not a third-party accrediting body that's checking in on them. I think in 2017, the certification process was put in place. It was before my time, but that's what I've read. And the certification is done by BHA, but it's definitely like a different sort of process than other behavioral health programs. And that leads to like limbo for a lot of these residences. We would contend that if you want to market yourself as a recovery residence, if you want to be a recovery residence, you should be certified. From my understanding, the reason that wasn't required is because of ADA concerns. But it doesn't, I'm not a lawyer, so I can't speak to it directly, but recovery residences, they are specialized programs. Like, you can be evicted for using drugs or alcohol. They limit the types of medications that you can bring into the house. That is not just an apartment. So having some sort of registration process, some sort of oversight for the state seems really reasonable to us, and we ask for a favorable report.
Thank you. Do I have any questions? Senator Lane.
Thank you, Madam Chair. Just a question, because I was looking at the testimony in the bill folder. So the Governor's Office for Opioid Response and the Special Secretary for Opioid Response referenced a concern. This is a lot of information, but concern about the deadline of January 1st, 2027, that it may be too soon. You open to?
I have no problem with us pushing it off if necessary.
Okay.
And now that you brought up their letter, I do want to mention, if I may, I neglected to say it before, the Department of Health specifically said that this would cost too much. They threw out a really high number. DLS in the fiscal note said that's not accurate, and they have a much lower number, so I'd urge everyone to read the fiscal note. But thank you for that question.
So I guess to follow up on that one then,
Yes.
with the effort that's required for MDH, are you envisioning, do inspectors need to go out before these are certified, or what's the process you envision as part of the certification?
So that's a great question, because it goes right into my next bill about inspections. Inspectors do need to go out originally to certify them. My next legislation would increase the amount of times they have to go out, and that we're going to get to in a moment. And that's where MDH in both pieces of legislation is saying, well, this is going to cost us too much money because we have to hire, and they gave an amount, I think 11 new people, but DLS said that that's not accurate based on the numbers they provided. They need maybe 4 or 5 new people to do this.
So I guess the process then is, recovery location would, apply, I guess, or notify MDH that I'm seeking certification.
Yes.
And then an inspection would need to occur prior to them receiving that certification,
Yes,
right?
that's
Okay.
correct.
And then some frequency of inspection that would occur on some regular basis later on, I guess.
That is correct, yes. And I'll talk in more detail again about the frequency as soon as we switch bills, if that's okay.
Sure. I guess then just a question about these two bills. Why are they coming in as separate bills? Was there a reason for that, or?
So there was not a reason when they were, well, that's not necessarily true. First, when we were, I've been working with the communities to come up with different ideas, and we've been having meetings about what the best solutions are. And first we had come up with a solution about certifying them, and then as we were looking, and the bill was being drafted, and then as we were looking more into it, then by the time we got both bills back, they were 2 separate ones. It was filed separately. But really, if it's okay to amend one into the other, that's perfectly fine with me. They really can just be one bill.
So it just was a process issue?
It was
I
just
guess,
a
'cause
process
The
thing.
issues are intertwined, I guess, based on how
Exactly,
you're dealing with
yes,
the policy.
yes.
Okay. All right. Thank you.
Thank
Thank
you.
you, Senator. I actually have a question for Dan. You said these are recovery houses, but they don't do counseling?
Correct. Yeah, the definition of recovery residence is it's like a supportive environment, and there's a limitation on drug and alcohol use. And they can, like maybe some of the better ones, some of the ones that are associated with other types of traditional treatment may have counseling or case managers or something, but like that's not the thrust of it. It's like a halfway house or a group home kind of is another synonym maybe for
So
that.
these are people that have been addicted that are trying to recover from, that's why it's recovery residence. So it's supportive, but not necessarily with counseling or services.
Correct.
Thank you. Any other questions? Senator Lamb.
I guess the chair generated another thought here. These locations, are they supported by federal or state dollars? Is this out of CMS
So the
or?
ones that are aren't certified, and you may be able to answer that question better, but they're not necessarily supported by either of them. Like, there are people I know in some streets, like one in my neighborhood, for example, someone just had a vacant house and they decided to call it a recovery residence, and a bunch of people just came and live in it. And I know, because I've been in there, that it's not a safe facility. So I don't know necessarily.
In that instance, who pays for it then?
Some could be private pay, but I'm not. Do you know better?
Yeah, I mean, most recovery residences require rent from the person who
So
is living
the
there.
individual is paying
Yeah.
for it. Okay.
You know, and these individuals often are not very, don't have a lot of resources. So there are, and it's very different from like one program to the next. So I don't want to overgeneralize, but that like rent is usually a component,
So
or
I guess
SSI or something.
right. I guess along those lines, is it a concern that since it sounds like a lot of this is just individual pay, the certification laid on top of the residences, obviously, I want to have decent residences for folks. Would it potentially could reduce the number of residences, which could drive the cost up for these individuals, or is that a concern or not?
What I would say is this goes back to the idea, just like regular rental, and we make it a requirement that you have to license your rental houses because safety is a priority, but it increases the prices down the line. It's the same concept. Someone's renting the facility, you're renting a bed in your house. We still want it to be safe. We don't want, just because someone doesn't have a lot of money, for them to be living in an unsafe facility. So it's really the same concept as a rental house that we regulate.
Okay. I mean, I guess there's a balance to be struck here. I mean, the governor's office of opioid response kind of pointed out that, we don't want these folks to just end up on the streets either, because it's probably worse. But
Absolutely.
I get what you're saying. So,
Absolutely.
so this should not jeopardize any, if this was being federally funded or Medicaid funded, this requirement for certification shouldn't affect that. It doesn't sound like this is being
No,
funded that way
because
anyway.
we already have about 300 of them that are certified.
okay.
Yes.
Okay. All right. Thank you.
Thank you.
See any other questions? That ends the hearing on Senate Bill 876. Senator, you're now going to do 878, and you have Laura Graziano from Galdenza coming up with you, I think, favorable.
Okay.
Yeah, I'm on that bill too, but should I sit down for now?
Well, you're going to be favorable with Amendment Dan, so you can just stay. It's fine. I'm just looking. Is Lauren here? I don't see her.
I don't see her as well.
Okay. Senator?
Thank you,
can start.
Madam Chair and Mr. Vice Chair and members. So this is kind of transitioning from the prior bill, and we were talking about how many inspections take place. And we have certified residences. As I mentioned, there are about close to 300 in the state of Maryland, and this is just focusing on the ones that are certified. The state of Maryland is supposed to make sure these facilities are safe. They give them the certification, and they can make unannounced visits. Now, a problem we're finding within our communities with the facilities that are certified is, and I don't want to blame the Department of Health because they may not have enough staff to do it, but they are not making frequent enough unannounced visits, that the certified facilities are kind of hanging around in the air as if they were uncertified, and some of these facilities are not safe when you go into them. The facilities are not good neighbors because they're not being monitored. So what this piece of legislation would do is it would require that the Department of Health makes at least 2 unannounced visits per year, and that's in addition to the original on-site inspection that they make. And then if they find that there is an issue, they're not in compliance with regulation and state law, then they have to give the facility a month to become up to date, and if not, they can revoke their certification. So I will say, and I'm going to jump to very quickly, the Department of Health, they put in a letter unfavorable because they said that this is going to cost too much money and take too much time, and they went into a little more detail, which you can read. Again, DLS said that they disagree with their assessment. This is not going to cost over $1 million to do, just based off of their own numbers that MDH provided and the amount of certified facilities that there are already. But if the committee decides that it would make more sense to change the amount of unannounced visits, make it less frequent. I understand that that may be the way to make this happen. I'm fine with that. I just want to make sure that these facilities know that the Department of Health will be stopping in, and you won't know when. They will make a visit, and if you are not up to date and in compliance with regulation, with state law, then they can revoke your certification. And hopefully, if we pass the first piece of legislation, if you don't have a certification, you can't be a recovery resident. So that will force people to make sure that they are following regulation, and we have safe facilities throughout our neighborhoods. And it doesn't continue to happen what we're seeing now, that these facilities are infiltrating our neighborhoods because they can do whatever they want and not be good neighbors and safe facilities. So with that, I would ask for a favorable report.
We go to favorable with amendment. Okay, I don't see questions. So we have Dan, favorable with amendment, and Teresa Hessler. Okay, Dan, you can start when you're ready.
Sure. Thanks, you, Chair. So, we're talking about recovery residents. I won't go back into it. Our amendment just tries to improve the feasibility of the inspection regime. There's already one inspection required per certification period. It's not specified whether it's announced or unannounced. And so our amendment would change it to one inspection required by the certification and then one unannounced inspection for each certification period. Certification periods are usually 1 year, but they can be extended up to 2 years if I think that's the limit that's in statute. And so once every 1 or 2 years, you would get an unannounced inspection in addition to the certification inspection. That would bring the fiscal note down in half, essentially. The other minor aspects of our amendment would say that the department or its designee could do the inspection or oversee the inspection. We're imagining the designee would be the local behavioral health authority, like BHSB. It's generally a partnership between BHA and LBHAs across the public behavioral health system. But because recovery residences, again, occupy this sort of unique space, BHA almost does everything with them. And we're saying, like, we're happy to help. And so by adding designee, we think that could help extend the capacity. And then the last aspect of our amendment indicates that the inspection isn't just about like the building and safety, but it's also about the programming or kind of environment of the residents. And we specifically call out whether they accept medications for opioid use disorder or not. We hear that a lot of recovery residences do not. So people with OUD show up and say, like, and they are told they need to get off those medications if they want to live there. And we don't think that that should be allowed as a certified recovery residence.
And Teresa?
Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the committee. For the record, my name is Teresa Hessler, and I'm here today representing the Recovery Housing and Treatment Center Coalition of Maryland, or RHTC. We respectfully support Senate Bill 878 with amendments. RHTC represents certified recovery residences and treatment providers across Maryland that deliver safe, stable environments for individuals in recovery. We strongly agree that oversight and accountability are essential to protecting residents and maintaining public trust as it pertains to certified recovery residences. However, we respectfully request targeted amendments in 3 areas. I have included additional details in my written testimony, but I will touch on them briefly. First, the scope of inspections. The bill does not define what an unannounced inspection entails. Clear guidance on those areas would be extremely helpful. Documentation, standards. This would help to ensure consistency and avoid unforeseen and uneven enforcement. Second, provider availability, and we definitely don't want providers to evade oversight. The bill should clarify protocols when residences are temporarily unstaffed. If it's an emergency, they have to run on site for something, or key personnel are off site for legitimate reasons. good faith providers should not be penalized due to operational realities. And third, consistency and predictability. We need clear guardrails rather than broad regulatory discretion and interpretation. I know for my providers in our group, there's a lot of differentiating depending on who comes out to do an inspection, differences between local departments in the state. So we'd like to see some consistency there. That will just help with transparency, fairness, and uniform enforcement. And so with that, we are committed to working collaboratively with this committee, with the sponsor, and with the department to ensure that individuals and the providers all work hand in hand. Thank you so much.
Thank you. Do I have any questions for these witnesses? Seeing none, that ends the bill hearing for Senate Bill 878. Thank you. Third bill today is Senate Bill 947, Maryland Transit Administration Reform Act. Senator McCray, are you here? Here you are. And you're going to bring with you Michael McMillan, Veronica McBeth, and David Pendleton.
Thank you, Madam Chair, and I'll be a little brief because I'm upstairs chairing the hearing too. For the record, Corey McCray, Senator for the 45th Legislative District, here before you all in reference to Senate Bill 947. Madam Chair, when we think about Senate Bill 947, it's just amplifying the voices of the local stakeholders that's back home in these respective jurisdictions, thinking through what does oversight look like, thinking through what does transparency look like, and thinking through like how do we make sure that our local folks are engaged in the governance of these respective boards. What you'll find here is a number of folks that there was a work group that was put together during the interim. Some of the folks that actually engaged while in the work group from that perspective.
Chair Bidle, Vice Chair Hayes, members of the Senate Finance Committee. Hello, my name is David Pendleton. I'm the Director of the Maryland Safety and Legislative Board for the Transportation Division of SMART. I'm here today urging a favorable report for SB 947, the MTA Reform Act. This bill will create the Board of Directors for the Baltimore Core Transit Services and the Commuter Services Advisory Board for MARC Commuter Rail and Administration's commuter bus service within the MTA. Furthermore, this law proposes a constitutional amendment allowing the administration certain condemnation authority and requiring MDOT to complete a technical study on the creation of a rail authority in the state. Reforming the MTA in this manner, allowing MARC to operate more independently within the MTA will allow it to be more efficient, growth-oriented, and attentive to the needs of the riding public. Our neighbor rail commuter agency, the VRE, has had similar authority for decades while also having similar operations to MARC. According to its CEO's report in 2024, VRE's operating expenses were $1.8 million under budget. Despite ridership being only 33% of pre-pandemic levels, these efficiencies were achieved without having to lay off employees or make cuts to its service. In fact, the VRE has managed to expand, starting construction on many capital improvements at several of its stations and facilities. To date, totaling $125 million worth of capital improvements, many more in the development and final planning stages, totaling hundreds of millions of dollars more, creating thousands of good-paying union construction jobs. MARC operates 3 times as many trains as the VRE, runs 7 days a week, and transports double the amount of passengers. Imagine what MARC can do if it were free to operate in the same manner. Once this model proves to be successful, imagine the positive reforms that could be achieved. Better service, more attentive to its customers' needs while creating and maintaining thousands of good union-paying jobs. Thank you for your considerations of our position, and SMART urges a favorable report.
Thank you, David. Michael McMillan?
Good afternoon, Chair Bidle, Vice Chair Hayes, and members of the committee. We thank you for this opportunity to come before you today. I'm Michael McMillan. I represent President Business Agent for Amalgamated Transit Union Local 1300. I represent the public sector employees for the MTA, the transit operators, and the maintenance employees. We will talk about how we got here. Back in 2015, with the cancellation of the red line, this was solely done under the governor's authority with no say by the riding public, stakeholders, or anyone. And we look at how thriving that the Trade Point Atlantic is doing now, and that red line corridor would have gave access to the people of Baltimore to be able to get to these jobs that are there with effective transportation. And that was just ripped from underneath of us. Fast forward into 2023, when the Maryland General Assembly, and we thank you for that, allowing the Baltimore Regional Transit Commission to come into play. What the BRTC did was give a voice to not only the riding public, stakeholders, and also labor, because labor, we have a seat on that board. We look at the disrepair and where funds was not being spent by the Maryland Transit Administration for repairs like with the red line. Had this commission been there, and they're doing great work then, and they're doing great work now. Had that commission been in there, I don't think we would be where we are. We're spending the millions and billions of dollars for disrepair and things that were left unnoticed. With that, even though it gives a voice to all that I just mentioned, it still falls just short of what's needed, and that is accountability and oversight. That's why we're urging that you, for 947 to receive a favorable report so that it can go to that next level and that next step so we can have the proper oversight of it. Thank you.
Thank you. Do I have any questions for this panel? Okay, Senator?
Can anyone explain the exemptions in the procurement law in this bill? Why is that needed?
Yeah, Mr. Chair, I think that the bill was aligning it with other agencies within MDOT, but let me be clear, I've been in the General Assembly for 12 years, and I know that once you create a bill, that it's no longer yours once it's before the committee.
Gotcha. Okay. I'm just like uber alert as it relates to exemptions to procurement law, especially in the environment when we get rid of MBEs, WBEs. And that section particularly may have an impact on union labor as it relates to construction. So I'm just concerned about that exemption. The other thing in the bill, what about, is there any specific reason, or are you also open to suggestions or amendments as it relates to the condemnation
Yeah,
provisions?
like I said, once it gets in finance's hands, it's the committee's product.
Gotcha. Okay. Thank you, Madam Chair.
That's a very smart answer, Senator. We appreciate it. I don't see any other questions for this panel. We have a few more favorables. Oh, I'm sorry, Senator Lamb.
Yeah, thank you, Madam Chair. So just to kind of follow up on the Vice Chair's questions here, I was looking at the Central Maryland Transportation Alliance, and they had brought up some points here. Just wanted to see what your thoughts on this were. So, you know, with this legislation, it would eliminate the Baltimore Regional Transit Commission, and then create this body that would be mostly appointed by the governor. And I know that we had referenced, and I think many of us share the same frustration with the red line being canceled. Is that at all concerning that, you know, the governor would actually have, you know, whoever the governor may be in the future, you know, would have a lot of influence over the, you know, this new body that's being created?
Yep, I want to recognize that some seats will be held by the local jurisdiction too, and most bodies, if not all that I've seen, the majority of the appointments come from the respective governor. I too was here, elected when we dealt with the red line, still frustrated with $2 billion being removed from the Baltimore region's economy, but I also recognize that it's not the person, it's the respective seat, and it's usually how we deal with a majority of that, any type of composition of a board.
Mm-hmm. And what was the intention behind having it staffed by, I guess, the state as opposed to the Baltimore Metropolitan Council, the BMC? Was that just, you know, to kind of take it out of that role, or what's?
I would say what I said to the vice chair. I've been here for 12 years, and if it's the will of the committee in reference to who staffs it, I think that's small fries in reference to what we're trying to accomplish with getting to amplify the local voices. So the core is around the local voices, the stakeholders, our local jurisdictions being engaged in these types of decisions.
Mm-hmm. Okay. All right. Thank you.
Yes, sir.
Thank you, Senator. Okay, now I don't see any more questions. for this panel.
Thank you, Madam Chair. I'm gonna get back upstairs if I can.
Okay. No,
HSCRC.
you certainly can. I'm sure David's capable of answering any questions that we might have. Thank you.
Thank you, Madam Chair.
Next, we're going to bring up Patrick Hosford from the Greater Baltimore Committee and Mike Kelly, Baltimore Metropolitan Council, for two more favorables.
Good afternoon, Madam Chair, members of the committee. I'm Mike Kelly. I'm the Executive Director of the Baltimore Metropolitan Council, testifying in favor of this bill. One of the things this bill does, as the prior commission just said, is to sunset the existing Baltimore Regional Transit Commission. And what it does, more importantly, is establish for the first time a real board over part of MTA. MTA is the only large transit agency in the country that
I need to ask you to stop just a minute. Can we keep the noise down so we can hear our people witnessing, please? Thank you.
Thank you, Madam Chair. MTA is the only large transit agency in the country that operates either without a board of directors or local government involvement. It's the only state-run transit agency without a board. This would establish a board with local representation, which we think is critically important, and that board would have actual voting authority. It's going to give jurisdictions a voice in things for the first time. You're going to see land use on the local side and transit on the state side finally being blended together, which is important to make transit investments work for the region. You're going to see transparency and accountability over decisions. You're going to see public meetings where things are discussed, which currently doesn't happen, just given the way MTA and MDOT are structured. And I think you're going to create an empowered board that's going to be able to advocate for the system, that's going to be a voice for the system. When we think back to the cancellation of the Red Line, a common critique was that there was no voice, there was no call for it. That's something we're hoping to remedy here. In terms of the composition of the board being majority state-run, when the work group was meeting, and I was on the work group that Senator McCray referenced, we have to recognize that MTA is a fully state-funded transit agency. The locals do not contribute funding. As a work group, even though I largely represent the local governments, we have to recognize where the money is coming from. And a governor-controlled board, which was, I believe, just a 5-4 majority, made sense at that point. I'll stop there. Certainly happy to answer any questions.
Patrick?
Well, good afternoon, Madam Chair, honorable members of the committee. My name is Patrick Hosford, Director of Strategy and Research at the Greater Baltimore Committee. And on behalf of the Greater Baltimore Committee, we serve as the leading voice for the private sector in the Baltimore region. GBC is in strong support of the Maryland Transit Administration Reform Act for the simple reason that its passage is really vital to advancing our regional economy. The Baltimore region has gone 30 years without a major transportation expansion. During that time, we've seen cancellations of the Red Line, which was mentioned, continued underinvestment in core bus and rail service, which was also mentioned, and a governance structure that leaves Baltimore leaders and transit riders and others stakeholders without a meaningful voice of influencing major decisions regarding projects, policies, and funding. Transportation is not, it's not just an issue about getting around, it's essential for supporting economic growth and access and opportunity. As mentioned today, however, the MTA operates with a structure where Baltimore's system has no dedicated board and no formal mechanism for consistent local oversight. And in fact, we're one of the largest transit systems in the country without this as well. So this legislation in particular creates a Baltimore Core Service Board with the MTA focused on specifically on a region's bus and light rail and metro systems. It preserves that state leadership which we were talking about as well, while ensuring a structured local participation, transparency, and accountability as well. It creates guardrails to protect major capital investments, really strengthens the coordination between state, transit decisions, and local use planning as well. We recognize that sustainable funding must also be addressed, but governance reform is necessary as a first step towards these ends. So on behalf of the Greater Baltimore Committee, the business community, we urge a favorable report. Thank you.
Before you leave, Veronica McBeth, you're here. You want to come to the table? We missed you on the first panel, Veronica. Just another favorable, and then we'll ask questions. Thank you.
Thank you and good afternoon. I'm here to testify in support of Senate Bill 947. Veronica McBeth, and I am the Director of Baltimore City's Department of Transportation. Senate Bill 947 advances several priorities that are important to Baltimore City and the broader central Maryland region, and strong coordination between the state and our local jurisdictions are essential to delivering reliable transit services in the Baltimore region. Establishing a governance structure that includes representation from Baltimore City, Baltimore County, and Anne Arundel County helps ensure that the communities most impacted by Baltimore's core transit network has a voice in shaping its priorities. This bill also promotes greater transparency and accountability in transit-making decisions. And clear oversight, regular reporting, and public engagement help ensure that service planning, capital investments, and long-term priorities are evaluated in a consistent and transparent manner. These reforms also support more predictable planning and delivery of transit investments. And for Baltimore City, coordination between state transit services and the city's roadway network is critical as we advance our multimodal corridors, safety improvements, and accessibility upgrades across our transportation system. For Baltimore, reliable transit is critical for options, and strengthening the governance and improving coordination between the state and our local jurisdictions will help ensure that transit investments align with broader regional transportation goals. And for these reasons, I respectfully request a favorable report of Senate Bill 947. Thank you for your time and
Thank you,
consideration.
Veronica. The Vice Chair has a question.
Thank you, Madam Chair. Mike, this is Baltimore Metropolitan Council a government entity?
Quasi-government, yeah, we're a creation of the legislature. We're in the code.
Got you. And so the exemptions to procure, because also the bill mandates that for whatever reason, MTA contracts with BMC, which is a little weird to legislate that we mandate a contract.
For the study purpose?
It doesn't say really, but I was wondering, so you all are unique in your designation as a quasi-government agency, and that's probably why that mandate is there?
I would think so, yes.
Okay, but that is not relevant. Does it have any relation to the exemption in state procurement that this?
No, it does not.
Okay, all right. Thank you, Madam Chair. That's all I have.
Thank you. Senator Lamb?
Yeah, thank you, Madam Chair. I don't know if this was a question for the prior panel or not. I was just kind of reading through this more. Is this envisioned as like a board to MTA, similar to like how the Ports Administration has a Ports Commission? Is that how this is envisioned? Like, are you envisioning that this would be almost like an oversight board, like a board of directors, board of trustees for MTA?
So it's a board of trustees for MTA's core service. There's a separate advisory board created for commuter services for MARC and commuter bus. And MTA it's unique that it's a statewide thing. And from the Baltimore region's perspective, we wanted to find a way to create a Baltimore region only voice at MTA. And that's why we focused on an empowered board over the core service area. And I believe it's an approval of the budget request, and there's 3 or 4 other actual approvals in there. And then an advisory board over the MARC and commuter bus. But yeah, it is the idea that you would have a board with specific powers over the core service area of MTA, so the bus, the light rail, the metro area.
The core service area just being certain types of transportation, or the area you mean is just around the Baltimore area? Because obviously MTA goes all the way out to probably to Frostburg and to
Correct.
wherever,
So the
right?
core service area is a term of art, meaning the area served by, it's essentially the area served by local bus. And that falls in Baltimore City, Baltimore County, and Anne Arundel.
Okay, so like service down to, this is Anne Arundel, but I guess service out to, Frederick,
Would
from
not be-
MTA doesn't fall under this.
Not under this, no. And that's by design. Now the advisory board over MARC service would deal with MARC service in Frederick.
Okay, all right, thank you.
So, Senator Hershey?
Thank you, Madam Chair. Just to follow a little bit with respect to the board and its decision-making authority, other than some references back to MTA procurement, how does this relate back to revenues and capital expenditures or operational expenditures? Is there advice or decision-making you guys would be providing with respect to that?
Senator, without the bill in front of me, I believe it's ultimately there's a fair amount of advice, and then the approvals are on the budget request. Ultimately, the budget decisions stay within the department. And then I do believe there is a specific power where the board would have to approve the cancellation of any project that was equivalent to the red line. I believe it's termed as a major capital project in the bill. And that was also by design to make sure there was a vote on a change like that in the future.
Right, okay. But overall, when the MTA is dealing with how it makes its budgetary decisions, is it just a guidance that you're providing, or is it any type of more formal interaction that you have with respect to that?
And I apologize if I'm not remembering the bill correctly. I believe it's advice on the back end on the final decisions.
Advisory, okay. All right, thank you very much, appreciate it. Thank you, Madam Chair.
Thank you. There was a time in my career that I chaired the Transportation Subcommittee in the House, and Mr. Kelly, I don't know if you remember, we had a significant meeting in your offices. There was a lot of people there, and we heard from employers that we needed east-west transportation, and it was the hospitals, it was Trade Point Atlantic, it was the ports. It's been at least 12 years since that happened. Have you seen any improvements on the east-west transportation in those 12 years?
Other than the current planning we're seeing on the red line now, and limited new service out to Trade Point now.
I mean, I still have significant transportation issues in Anne Arundel, as you probably know, with the airport and Maryland Live and business people that can't get to work at odd hours, because we don't have any transportation that runs to have people at the airport by 5 in the morning. So I appreciate your work and thank you for being here. Do I have any other questions for this panel? I don't see anything. Thank you very much.
Thank you very much, Madam Chair.
We have one more favorable with amendment, and then we have one virtual. So George Tolley, favorable with amendment.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the Finance Committee. My name is George Tolley. I'm very grateful to you all for this chance to talk to you about Senate Bill 947 and the position of the Maryland Association for Justice with respect to 3 lines out of this 25-page bill, 3 lines on page 15. The work group that you heard about wasn't charged with looking at tort liability, but they did. And they adopted some language that MTA has tried and failed year after year for the last decade to get the Judicial Proceedings Committee and or the Judiciary Committee to look at favorably. Neither of those committees has ever approved a tort cap on liability of the MTA. And let me tell you why I think that's true. MTA is the successor to the Baltimore Transit Company, a private company that wouldn't have been, when the State Tort Claims Act was created, wouldn't have been subject to the act. And so this body, the legislature, decided to leave MTA out of the State Tort Claims Act. MTA does have advantages. There is a notice requirement in 1 year. You have to write to the treasurer if you want to make a claim. But there's no cap, because the things this bill, these witnesses just told you, this bill is all about, better service, more attentive to customer needs, and accountability and oversight, are all inconsistent with a cap on damages applicable to a common carrier, right? They run buses and trains, and common carriers have a heightened duty under the law of care for the passengers that they're transporting. What a hard cap like this does is different from what you may remember. We have a non-economic damages cap in tort liability, which does apply to claims against MTA. And so MTA is responsible currently for all of the economic harms, but not all the non-economic harms. My time is done, but I'm happy to answer any questions. Thank you for this consideration.
I don't see any. Thank you very much for your testimony.
Thank you, Madam Chair.
And now we have virtually John Laria from the Baltimore Regional Transit Commission. Good afternoon.
Good afternoon. Can you hear me, Madam Chair? Can you hear me?
We can hear you, John.
Madam Chair, can you hear me?
Yes, we can hear you.
Oh, I'm sorry. I apologize. Well, thank you, Madam Chair, members of the committee. My name is John Laria. I'm the chair of the Baltimore Regional Transit Commission, about which you've heard. And in that capacity, I was a member of the work group that led to the introduction of this bill. As Senator Lamb said, the bill would replace our commission with a new MTA Core Transit Service Board, but I hope you will not be surprised to hear that I am in full support, and I want to explain. The BRTC grew out of a Baltimore Metropolitan Council study, which finally acknowledged a few years ago that the current MDOT MTA structure was not working well for MTA, and certainly not for MTA stakeholders in the Baltimore region. The creation of the BRTC in 2023 was a step in the direction of improvement and reform by creating what is essentially an advocacy body for and an advisory body to MTA. And I hope and believe we've been good advocates and given good advice, but our experience these last few years has taught us that it is not enough. While we have local representation appointed by the mayor, by county executives and other stakeholders, we are constrained by what is fundamentally and frustratingly advisory role. It's not that MDOT and MTA have not been good partners, they have, but ultimately our ability to exert any real control over regional transit service is limited, especially with respect to budget priorities. And the work group, in fact, identified that as its problem statement. Unlike the current BRTC, the new Core Transit Service Board would be required to approve, not just review MTA's operating and capital budget requests, as well as major service plans, policies, and initiatives. And as you've heard, also would require a supermajority for the withdrawal of certain major, massive capital projects, such as the Red Line, which was canceled by a prior governor with literally no input by the affected parties. As you've also heard, the bill would also make badly needed improvements that are not strictly about the local representation issues, but lead to economic efficiencies at MTA, personnel matters, tort liability, quick take authority, and procurement. You've heard about those from others. I'd be happy to elaborate on any of them, but the bill delivers the accountability, transparency, and regional responsiveness that the system and its riders deserve, and at the same time make it easier for MTA to fulfill its critical mission. We respectfully urge a favorable report. I'd be happy to answer any questions or go into further detail on any of those points. And thank you very much.
Thank you, John. Do I have any questions for Mr. Laria? Seeing no questions, thank you very much. And that ends the hearing on Senate Bill 947. And now we're going to go to Senate Bill 951. Has everyone come in from the hallway that needed to? Okay. Let's give a minute to make sure we're in. But you do have to have a seat. So if you have too many people here, people are still going to have to wait out in the hallway. So if you're testifying, you want to make sure that you're in here and have a seat. I hate this. Who the heck did this?
Once every seat is full, the remaining people have to wait outside.
Have to wait outside. I'm going to call the first four people. They can have a seat at the table. Here you go. Senator Ellis, you have someone else presenting? Yes, okay, thank you. Jane Cranky, Dan Shattuck, Shane Angus, and Camille Fesh can come to the table, so that opens up 4 seats. Of course, once you're done testifying, you'll have to wait outside because your 4 seats will be filled. So, okay. Okay, you can begin your testimony. Thank you.
Good afternoon, Chair Beidel, Vice Chair Hayes, and members on the Senate Finance Committee. I am Sahithya Venkatesh, a legislative intern in the office of Senator Ellis, who represents District 28 in Charles County. I am presenting on Senate Bill 0951. There is a shortage of medical professionals, and specifically, there is a shortage of people who work in anesthesia. This bill aims to remedy this problem by opening up the available workforce for medical professionals. Senate Bill 951 is a simple, straightforward bill. It licenses anesthesiologist assistants in Maryland. It defines their scope of practice and sets up training standards and regulatory oversight under the Board of Physicians. As you will hear from the panel, Senate Bill 951 aligns Maryland with 23 other states, including the District of Columbia and Virginia, and helps address hospital staffing challenges, particularly in surgical and procedural settings, under closely regulated conditions. With that, I will turn it over to the panel, who can speak to this bill in detail and explain why it is so important. Thank you.
Thank you.
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. For the record, my name is Camille Fesh, representing Children's National Hospital, here in support of Senate Bill 951, the licensing of certified anesthesia assistants. First off, I want to point out that Children's National Hospital in DC, 60% of their patients are Marylanders. And so CAAs are permitted to practice in DC, which means that the Marylanders that come over the border into DC for care and treatment are CAAs can safely and successfully practice as part of the anesthesia care team. However, these patients cannot receive the very same style of care here in Maryland, and that is something we're looking to remedy. Nationally, CAAs practice in over 23 jurisdictions, including the District of Columbia and Virginia, and states continue to adopt CAA licensure by wide bipartisan margins. Most recently, Nevada, Tennessee, and Washington State have passed legislation. Nothing in Senate Bill 951 removes, restricts, or limits the education or clinical training of any anesthesia professional. As was stated, as the population is aging, as the doctors and medical professionals are aging, there's simply not enough people working in anesthesia, and this is a problem that will continue to grow quite dire in the next several years. So this licensing CAAs in Maryland will not take cases away from other anesthesia trainees or anesthesia professionals. It simply adds another qualified, nationally certified member to the care team, to the physician-led anesthesia care team. So facilities have more staffing options to meet patient demand. Also, as you will hear, we have a number of Marylanders that have been born, raised, and educated in Maryland, but yet cannot practice their medical profession in Maryland. And before my time runs out, I'll let you know that you'll be hearing from the Maryland Hospital Association, the Maryland Society of Anesthesiologists, the American Academy of Anesthesiologist Assistants, the Maryland chapter, and from the Chief of Anesthesiology at Children's National Hospital. Thank you very much, and we look forward to any questions.
Thank you, Camille. Who's next?
Madam Chair, Mr. Chair, Vice Chair, members of the committee, I'm absolutely delighted to be here today to speak in favor of SB 951 on behalf of the American Academy of Anesthesiologist Assistants. My name is Shane Angus, and for over 26 years, I have been a certified anesthesiologist assistant. 13 of those years, I've lived in Maryland and transited into DC to practice. Additionally, I'm an associate professor with the School of Medicine where I focus on anesthesia education and patient safety. The CA profession is a 55-year-old profession, similar to PAs. We complete a graduate level anesthesia-focused degree associated with a medical school, and we meet national certification and accreditation standards. And additionally, we focus and specialize exclusively within the anesthesiologist, physician-led anesthesia care team. Many CAAs also come with some amazing prior experience in acute care, especially high acute care. We have Maryland firefighters, EMTs, PAs, nurses, nurse practitioners, foreign trained physicians, and researchers. These matriculants are incredibly highly qualified, and their acceptance criteria is on par with medical school. Many CAAs are Maryland educated at schools like the University of Maryland, UMBC, Towson, Hopkins, Salisbury, and the United States Naval Academy. Many already work in DC, where for the past 20 years we have practiced under a license, which is the national standard of approach within the boards of medicine. We train and work in every single DC hospital alongside our nurse anesthetist colleagues within the care team model. SB 951 is pretty straightforward. It creates Maryland license following national standards, keeps the anesthesiologist supervision clear, and adds needed capacity. Thank you very much.
Thank you.
Good afternoon, Chair Beidle, Vice Chair Hayes, and members of the Finance Committee. My name is Jane Krinke. I'm here on behalf of the Maryland Hospital Association in strong support of Senate Bill 951. We believe this legislation will help close the gap between the supply of anesthesia providers and the increasing demand for anesthesia services. As you've heard, there are 23 jurisdictions that license these healthcare workers, allowing physician-supervised model to expand in the number of cases they're able to provide under direct supervision from a physician. We believe that passing this legislation aligns with Maryland's work to modernize the healthcare workforce to meet the changing needs of our healthcare delivery system. This committee has a history of doing this. Back in 2024, given the growing shortage of radiology technologists, this committee passed legislation to expand and create a new licensure exception, allowing lower acuity patients to seek care in the community. Similarly, this legislation expands the ability of physician anesthesiologists to supervise additional cases, delivering care to more Marylanders, both in hospitals and ambulatory surgical centers. As care increasingly moves outside the walls of our hospitals, we need to support the growth of our healthcare workforce to continue to meet that need. Taking these steps are important to modernize the workforce, especially as we're entering the AHEAD model, with focuses on looking at primary and community-based care, improving population health, and containing cost in lower cost settings. We'll continue to see more care delivered outside of the hospital walls, and we need a healthcare workforce that can help support this. It's important that we're nimble and flexible to accommodate these changes, and that's why we're in support of this legislation and ask for a favorable report. Thank you.
Madam Chair, members of the committee, I'm Dan Shattuck here today on behalf of the Maryland Society of Anesthesiologists. I serve as their executive director. So we're here in support of Senate Bill 951. The Maryland Society has been working on our workforce issues for a number of years. We've been working with our hospital partners, legislative leaders, and agencies like the HSCRC. In fact, we were here a couple weeks ago to testify on a bill that is looking to allow the HSCRC to take into consideration hospital costs, particularly those costs used for physician and providers. This bill is important because it's a piece of the puzzle in this workforce equation. As you've already heard, there is a shortfall of anesthesia providers. That's going to continue to grow as the population gets older. This need is real. We've actually surveyed our members a couple of times over the last 3 years, and the story hasn't changed. It's getting harder to recruit and retain anesthesiologists. A lot of that is due to the changing conditions of the workforce. We have an aging population of providers. There's an increased need for work-life balance, and there's also the reimbursement and high cost of living issues in the state of Maryland, and we're working on other bills to address that. What this bill is going to do is open the door to CAAs. You've heard they work in DC, they're going to be working in Virginia. They're a proven profession that's ready to come in and start day one. We don't have to wait while we stand up a new profession. We'll have to stand up some regulations, but as we look at the staffing needs and the challenges our practice groups are facing, what I'm hearing is from my docs, it takes between 6 and 12 months to recruit one anesthesiologist to come and join a practice. If we can have this ready workforce, on our doorstep, ready to come in, I think that's just going to help increase the possibilities of solving this workforce shortage. I just want to make a quick note in 2 seconds. The Board of Physicians did note some statistics in their letter of opposition that there isn't a shortage problem when you look at per capita numbers, but you can't look at the number of licensed anesthesiologists on a per capita basis. Not all of them practice full-time. Some maintain state licensure in Maryland but practice in other states. Some only practice pain management. Some are just specialists like pediatric and cardiac anesthesiologists. So there's a lot to consider, and we thank you for your consideration.
Thank you to this panel. Senator Washington.
Thank you, Madam Chair. I just want to I'm looking at the testimony from the Maryland Academic of Advanced Practice Clinicians. Small font on that. And so they say that anesthesiologist assistants are not APRNs. They do not hold nursing licensure. They do not bring ICU level critical care preparation, and they cannot practice autonomously. Introducing this provider category alongside Maryland's established APRN workforce does not enhance the system. It adds a dependent tier, the part that concerned me, that competes for the same clinical training resources while offering a narrower scope of deployment. Can one of you respond to that?
I can, yeah, sure. Thank you very much for that question. Yeah, so we work similar to how an NP and PAs might work collaboratively and interchangeably in different environments. And so I think there's, a variety of places people can come from and experiences people can come from. As I mentioned, some of the people who are in our field are firefighters from Maryland, who are foreign trained physicians. And so they bring different skill sets, but those skill sets are incredibly valuable when it comes to the anesthesia care. And it's really important, too, to note that we practice exclusively in the care team model. Yeah. As far as the clinical training sites, there are a significant number of practitioners in the state, and so there's always that opportunity for increased resources for education with those instructors that are available and waiting to teach.
Yeah, but it says it as a dependent tier. Is that true?
I'm not sure. So as far as dependency, we work exclusively in a care team model. Yeah. So we are dependent on.
So there's another level of, because what I'm assuming they're saying here is that the APRNs, are autonomous. They can do a lot more, whereas this AAs, the anesthesiology assistants, are dependent more so.
I think it's terminology, perhaps. I look at this as a care team, just like you might have two pilots in an airplane, in a commercial plane, having two people, two anesthesia providers is a wonderful asset to have. So that's my perspective on how my care would be appreciated, having two people available. CRNAs are not independent in Maryland. Oh, and my understanding is that the CRNAs are not independent in Maryland. Is that there may be some APRNs that are, but CRNAs are not. That might be a correction.
I think it'll clear up later. We have some other testimony coming that'll clear that up. Good question, Senator. Thank you.
Thank you.
Senator Lamb? Oh, are you finished, Senator?
Yes, I'm finished.
Okay. Senator Lamb?
Yeah, thank you, Madam Chair. So I guess just trying to get some clarification here. I was just looking through the bill again and, looking through terminology and such. When I was looking through this, I guess the supervision piece wasn't, entirely clear, which is why I want to ask this question. It makes it sound like that, at least in some cases, some instances, there would be an anesthesiologist that would be in the room, I guess, in the OR. If it's true that the anesthesiologist can actually already use like a medical assistant under current statute and delegate duties to that unlicensed person, I guess why would this be needed then if doctors can already delegate medical duties to unlicensed medical assistants that they're directly supervising?
Yeah, I'm going to take a stab at that. So in Maryland, for anesthesiologists, there's a prohibition for them to delegate their duties to an assistant. They can't work with PAs. There was like one PAAA in the state of Maryland who retired a few years ago. But traditionally, when anesthesiologists are working with another anesthesia provider like a CRNA, the CRNA is trained and qualified as the AAs are to administer the anesthesia, but an anesthesiologist can't delegate that administration authority to anyone else. It's right now in Maryland.
Is that specific to anesthesiologists, or because my understanding is that in the statute it allows other physicians to.
Right. There's language in Maryland statute that prohibits the delegation of the administration of anesthesia
specifically on that.
To a medical assistant.
Okay.
Or a medical provider. Yeah. It's only dentists, physician anesthesiologists, and CRNAs that can administer anesthesia in Maryland, and this would add AAs to that equation.
Okay. Based on some of the definitions that are in this bill, does the anesthesiologist need to be in the OR or on site at least, or how? If you could just clarify that.
Yeah, and I can let.
Happy to take that one. So the way the care team model works is there can be one attending anesthesiologist that can cover up to 4 different other providers with them. And so that is up to the discretion of the attending to kind of determine how best that balances out, right? Whether it's an incoming trauma or a major cardiac or a liver transplant, that's where you might have 1-to-1. But the variant will go up to 1-to-4. A lot of that is based upon federal CMS guidelines and TEFRA guidelines on what they can do and can't do, and most insurance carriers follow that example and meet that one.
And I get that, but what does do they need to be on site, or can it be off-site delegation?
Off-site.
Or
no, they have to be to meet the TEFRA requirements. They have to be there physically.
So they have to be physically in the same regulated space?
Generally, that's what the jurisdictions will define, what that regulated space is. Most jurisdictions have an incredibly hard time defining what that space is, but most sort of say, like, you need to be there physically present.
Okay. So when it comes to the case that's being made about access, expanding access, the access is really just limited to that physical space, right? So a CAA can't be practicing out in Hagerstown on their own because they're not in the same regulated space, I guess. Right?
Correct. The way the anesthesia care team model works is that it's exclusively within the attending anesthesiologist is present and physically available.
Okay.
And that's what most people practice in. Nurse anesthetists and anesthesiologists assistant practice in that model.
Okay. And then I guess last question here. You know, I guess on the cost of this, right? So the cost of these are going to be borne by the Board of Physicians, right? So the Board of Physicians is usually predominantly self-funded by physician fees, licensing fees. And so, you know, I presume that the fee that's going to be charged to CAAs is probably not going to fully cover the effort required to be undertaken by the board to cover all of the expenses here. So some of this is going to be borne by other licensees under the Board of Physicians, including the physicians, I guess. Is there any openness, since these are folks that are going to be practicing in a hospital, to have some of that distributed back towards the facility or the hospitals to help chip into that, or is this all being borne on the backs of physicians?
That's a great question, and no, it should not be on the backs of the physicians. Traditionally, in all the jurisdictions, it falls on the licensee's fee to cover those costs so that there is a net balance on the sheets. There's no other additional fees or expenses by any other individual who's licensed within that board. So we have, I believe in the bill, there's lots of deference to the board to determine what those fees are. And you are correct. By far, I've never worked in a place before in my 26 years where either the group or the hospital didn't reimburse me for those fees. So there's been some type of a, you know, educational fund or licensing fund as part of the employment agreement. And that fee from the hospital, the group, paid for that license.
So you're saying that in that instance, the hospital or the facility is paying for indirectly anyway via the CAA, or I guess in this instance?
Yep.
Okay. Because the fees could be high, you know, to set this up. It could be a significant regime to set this up for the Board of Physicians, right? Yeah. So, so you're comfortable with that arrangement?
Balance books. I think that's very important.
Okay. And then maybe if you can just get back to us afterwards with this, you know, how many CAAs have finished training since 2016? So it's been 10 years since this was introduced before the General Assembly before. Yeah. How many additional CAAs have been trained in that 10 years where this law wasn't in place?
That's a great question. So there's a program in Washington, D.C., and that program graduates currently 36 people. So it's been 36 for maybe the past 5 years or so. A little small class before that. So in the last 10 years, it graduated about 350 people from that one location.
Okay.
And nationally, there are 26 schools across the country. Some are at large major public institutions, some are private institutions. And summatively, I think there's about 600 seats per year right now.
Okay. All right. Thank you.
Senator Rowland?
Senator Lamb asked everything I could
Okay.
imagine.
All right. Senator Ellis?
Thank you, Madam Chair, and thank you for being on this panel, and thank you for the bill presentation. So this is like my 8th year dealing with issues around licensure. First on was now the Triple E Committee in the last 4 years here in finance. Let me ask you, Mr. Angus, really quick, really kind of, you were talking, to a little technical question, you were talking about, I think, training institutions, and you mentioned one of them was like the Naval Academy. So could you, are you familiar with what I'm asking?
Yes, I believe so. I can expound on that.
Yeah.
What I was referring to, Senator, was that the academic programs that receive students to become a CAA, there have been multiple who have attended the U.S. Naval Academy and who are now currently practicing CAAs. So we have people who are, commanders in the Navy who are also CAAs.
Okay, so you were referring to midshipmen graduate from the academy, go into this program? At any schools in Maryland, or?
Unfortunately, no, sir. There are no schools in Maryland.
Okay.
Yeah.
Yeah. Does the Uniformed Services University have that program,
No, sir.
Bethesda?
I do not. I wish they did, though.
Wish they did.
So did our people who went to the Naval Academy, wish that they could have gone there as well.
Yeah, okay. I was just curious. Thanks for that. Mr. Shattuck, so, in many years you've been here, these bills that create new licensure create quite a bit of conflict.
Mm-hmm.
And some people classify them as fighting over turf, basically, right? What's your opinion on that and this particular legislation?
Right. I don't see this as a turf war, a turf battle, because we have a need in Maryland for anesthesia services. We have a need for, a growing need for these services.
Mm-hmm.
And what I've heard from our members, and you'll hear from some physicians that'll follow me, is the need to keep the operating rooms open and to keep throughput moving. And your committee has heard about throughput problems. We've talked about ED wait times. So if there's any kink in the chain, it's going to cause backups through the system. And what we have here is an opportunity to take a proven provider. We're not starting from scratch. We're not having to, create from the ground up a new profession. We're trying to just open the doors to bring in that provider here, and there's plenty of work to go around. And I think you'll hear others say as well that everybody's valued in this space, and everybody's worked together collegially in this space. Anesthesia is a very delicate area, but it's a very important area, and I'll look to the hospitals. A hospital can't run, when I say operate, without an anesthesia department. And you need people 24/7. You need people working, 8-hour shifts or coming on shifts, coming off shifts, keeping those ORs open and moving. And if there's an opportunity to solve that now, or not solve it, but push towards a solution now, I say we need to take it.
Yeah, and basically in meeting with the proponents for this bill, especially folks at Children's Hospital, which provides such a great service to our kids, and believe that this legislation will help, that population group is very, very meaningful to me. Ms. Fesh, so you represent Children's Hospital directly. And
Correct, yes.
So what's the impact of this bill passed would have on the operations of Children's?
Well, Dr. Tasher, who is the chief of anesthesiology at Children's, is coming on the next panel. He can probably answer that question more fully, but this would allow Children's to use CAAs in Maryland and ambulatory surgery centers, in the ambulatory surgery centers that they have in the ring surrounding the DMV.
Okay. When you say CSA, we have people listening online. When you say, what's the term CSA? That term you use, CSA?
CAAs, Certified Anesthesia Assistants. Yes.
Okay.
So that would be, this particular license would be Certified Anesthesia Assistants, or CAAs.
Okay.
So, and anesthesia, anything with anesthesia or anesthesiologist is quite a bit of a tongue twister.
Yeah.
So I usually abbreviate to CAAs.
Yeah. Would that term be, is that in the legislation to just say instead of the tongue twister?
Well, hopefully not. But yes, the official title of this license would be Certified Anesthesiologist Assistant.
Great, thank you. Thank you, Madam Chair.
Thank you. And I think that ends the hearing. And Sahitha, thank you for your presentation. You did a really good job. Thank you.
Thank you.
I have another panel of favorables to call up. Dr. Brad Tasher, Ashley Bagwell, Jacqueline Babin, Millicent Kihiria, and Dr. Ram Parugma. Who would like to start? Okay. Doctor, once you start, we're just going to go right down the aisle, if that's okay.
Thank you. Thank you, Madam Chair. I thought I'd start as the president of the Maryland Society of Anesthesiologists. I'm Dr. Ram Paravemba. Nice to see all of you again, and thanks for the opportunity to testify in support of Senate Bill 951. I'm in support of this bill for two main reasons. First of all, I've seen and worked with my colleagues during a time when there was a significant shortfall of providers over the last few years. It's to the extent that largely we've had to get folks from out of state as locums providers or 1099 providers, which has been an additional cost burden to us. And as we've discussed in other bill situations, it's a cost back to the hospitals who then have to reimburse these providers. And we've talked about the reasons for the shortfalls in anesthesia groups, including low reimbursement in the state of Maryland and other factors. But ultimately, by having anesthesia assistants come to Maryland, we can provide another pool of providers that can try to soften the shortfall in the costs. Second reason, which has been brought up several times, is the maintenance of the care team model. Just to address some earlier questions, in case it doesn't come up again, care team model already exists. We feel it's the safest method for caring for patients. It's done at the Children's Hospital. And under that model, the anesthesia assistants can provide care under the supervision. We're in the facilities, and that will help in underserved areas as well, because if we need 4 rooms covered, we can have 1 anesthesiologist and 4 AAs. So ultimately, because of their training and because of these factors, I support this bill. Thank you.
Thank you. Who's next?
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the Senate Finance Committee. My name is Millicent Kahiria, and I was born and raised in Salisbury, Maryland. I attended the University of Maryland in College Park, and after graduating, I spent a year conducting research on opioid use disorder in Federalsburg, Maryland. When it came time to choose a career, the CAA profession felt like a perfect fit. And with less than 2 months left in my training, I know it truly is. I find deep fulfillment in caring for and advocating on behalf of patients. This career offers everything that I could have hoped for, except for one important piece, the opportunity to practice back home in Maryland. Returning home to be near my parents means a great deal to me. And as a lifelong Salisbury resident and a graduate of UMD, this state is not just where I'm from, it's who I am. Over the past 2 years as an AA student, I have cared for patients in Washington, D.C., where CAAs are licensed to practice. Many of these patients are Maryland residents. If I am entrusted to care for Marylanders in D.C., why can't I care for my fellow Marylanders in our home? Having lived on the Eastern Shore, I have seen firsthand the impact that healthcare workforce shortages have on our community. Expanding CAA licensure to Maryland would help bridge this gap, improving access for patients, while allowing Marylanders like myself to return and serve the communities that shaped us. While I am excited to begin my career as a CAA at MedStar Georgetown in DC in the coming months, I remain hopeful for a future in which I can practice in Maryland and finally come back home. Thank you for your time.
Hi. Thank you, Madam Chair, Mr. Vice Chair, and to the Senate Finance Committee for hearing us today. My name is Jacqueline Babin, and I'm a certified anesthesiologist assistant and a Maryland resident. I was born and raised in Maryland, and I have since set down my own family's roots in Maryland. I graduated from Case Western Reserve University's Master of Science in Anesthesia DC program in 2020 in the middle of the COVID-19 pandemic. I have since worked for almost 6 years now at a level 1 trauma center in DC. I am the student coordinator for the AA students, and I work directly with student coordinators from other anesthesia professions at my hospital. I can tell you firsthand that we do not displace any students, and we do not restrict preceptorship. We collaborate on providing opportunities for our students. In states where CAAs practice, both the CRNA tract and the CAA tract grows because the workforce is needed. I'm also the president of the Maryland Association of Anesthesiologist Assistants, and I represent my membership, those in Maryland who have to cross state lines just to do the job they were expertly trained for, and those that have had to move away from their hometowns and their families so they can do their job. I myself live 10 minutes away from a community hospital that I pass every single day on my hour-long commute into DC. It's where I was born and where I had my first shadowing experience. So I urge you, on behalf of our students, on behalf of my membership, and just for myself, to please say yes to Senate Bill 951 so that Maryland CAAs can serve their own communities. Thank you.
Madam Chair, Vice Chair, members of the committee, thank you for the opportunity to provide testimony in strong support of Senate Bill 951. My name is Dr. Brad Tasher, and I'm the Chief of Anesthesiology, Pain and Perioperative Medicine at Children's National Hospital. I also serve as the Associate Vice Chair for the Society of Pediatric Anesthesiologists Committee on Quality and Safety, and I'm a Maryland resident. Nationally and here in Maryland, the anesthesia workforce is experiencing a critical shortage. The shortage is even more concerning in pediatrics as fewer medical student graduates are entering into pediatrics, let alone pediatric anesthesiology as a specialty. Senate Bill 951 addresses this critical workforce gap by licensing CAAs and expanding access to safe, high-quality anesthesia care. As the region's only standalone children's hospital, we have utilized the anesthesia care team model in DC with the inclusion of CAAs for the past 20 years. This model allows us to maximize our staffing resources and provide safe and efficient access to anesthesia service for our patients, the majority of whom are Marylanders. As you've heard, CAAs can practice in 23 states and jurisdictions, including DC and Virginia. Licensing CAAs in Maryland will have a direct impact on Children's National, being able to provide care to the greatest number of Maryland children closest to home. 43% of our CAAs live in Maryland, but work in DC. If this bill passes, they would be eager to provide care for kids in Montgomery and Prince George's counties, where our ambulatory surgery centers are located. This is significant because since the height of the COVID-19 pandemic, we have been unable to fully open all of our operating rooms due to ongoing staffing constraints. We need the full range of anesthesia providers, anesthesiologists, nurse anesthetists, and CAAs to better serve Maryland patients. Passage of this bill will help expand access to high-quality anesthesia care for patients across Maryland. Thank you to Senator Ellis for introducing this legislation, and we hope for your support.
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. I'm Ashley Bagwell here this afternoon on behalf of the Maryland Association of Anesthesiologist Assistants in strong support of Senate Bill 951. I'll make a few final comments focusing on some of the issues that were raised in the Board of Physicians letters. First, regarding statutory alignment, I know that this committee spent a lot of time last year on Senate Bill 423, and so to the extent that there is language required in last year's Senate Bill 423 that is not in Senate Bill 951, we believe that that can be easily fixed with an amendment. Second, as Mr. Shattuck on the previous panel indicated, this is not a new issue, generally speaking, and not a new profession. And this is also a topic that this committee has taken up previously. I don't want to belabor the point, but I will just flag for this committee that this is an issue that we initially brought up with the Board of Physicians starting last July. I will commit to this committee the same way that we committed to the board that we are happy to provide any additional data or information that's helpful to y'all as y'all deliberate this legislation. And then lastly, I will just say that we do strongly believe that the Board of Physicians is the appropriate home for anesthesiologist assistants. They work under the direct supervision of anesthesiologists and fall under the Board of Physicians in the other 23 states where they are licensed. So with that, Madam Chair, we would urge a favorable report.
Thank you. Do I have any questions for this panel? We have no questions. Thank you very much for your testimony. Thank you. Okay, so now we have the panel of unfavorable. Bill Kress, Kenneth Radford, Matthew Zinder, Shannon Seifert, Matthew D'Angelo, and Jacqueline Mitchell. 1, 2, 3, 4. I think you can all fit in there.
Yep.
Which side should we start on? Okay, you want to start, you're Ken, right?
Yes.
You want to start here for me and go down?
All right. Madam Chair, Vice Chair, members of the Finance Committee, good afternoon. My name is Ken Radford. I reside in Frederick, Maryland, and I'm the president of the Maryland Association of Nurse Anesthetists, and I'm here today to speak in opposition of licensing anesthesiologists assistants in Maryland. Maryland already has a gold standard anesthesia care model, one that is used by the U.S. military to include U.S. Special Forces. This system relies on two highly trained providers, anesthesia providers, that are nationally and federally recognized, physician anesthesiologists and CRNAs. Both are fully licensed, both are trained to make immediate life-critical decisions, and both are legally empowered to act when seconds matter. This structure is not accidental, it's a policy safeguard. CRNAs on average have 3 to 5 years of high acuity critical registered nursing experience before entering anesthesia training. That means every CRNA in Maryland has already managed ventilators, vasoactive infusions, cardiac arrest, and unstable critically ill patients long before stepping into the operating room. Independent collaborative care also creates system elasticity because every current anesthesia provider in Maryland is a decision maker. Hospitals can move cases efficiently, respond to emergencies, and adapt in real time, especially in community and rural settings. Introducing a dependent assistant provider role, such as anesthesiology assistants, does the opposite. Creates a bottleneck tier of assistants who cannot legally proceed without supervision and direction, which reduces flexibility while slowing care in a system that is already meeting Maryland's needs. In closing, we already have the gold standard of anesthesia care in Maryland. CRNAs have provided watchful care in the U.S. for over 150 years. Since 1946, the founding year of the association I represent, CRNAs have stood as trusted partners to deliver anesthesia care for Marylanders, and we will continue to do so well into the future. What Maryland needs today is to protect what's already working, CRNAs and physician anesthesiologists working together for Marylanders.
Thank you, Madam Chair, Vice Chair, and members. My name is Matthew Zinder. I've been a Maryland CRNA for 22 years. I own an anesthesia practice. We are an independent CRNA-owned practice. We've been in business for 42 years. We are a family-owned CRNA business. I also speak all over the country on the business of anesthesia. And with that experience and research, what I can tell you is the AA model does not make financial sense. We can talk about the difference between medical supervision and medical direction through questions, if you wish. I don't think I have enough time to speak on it now, but AAs have to work under a medical direction model, which means those are federal regulations to bill Medicare. That means you have to follow, as stated before, regulations that govern the presence of an anesthesiologist in a room with an AA during critical moments of an anesthetic, which generally is induction, emergence, and any critical moments other than that. In a study published in Anesthesiology, which is called the Epstein study, they found that in a ratio of 1 to 2, they were 33% out of compliance with those federal regulations. And in a ratio of 1 to 3, 99% out of regulation, out of compliance for these federal regulations. So also to clear up a couple things that were said, in Maryland, we CRNAs are in a collaborative model. which means in my practice, I can tell you, again, we've been in business for 42 years, and we cover freestanding surgeon-owned single specialty ambulatory surgery centers throughout the entire state. We work alone in these facilities. They're freestanding. We have collaborators. The collaborators are the surgeons, and I also have an anesthesiologist that works with me in my practice, but not on site. We're allowed to do that in Maryland. I'm out of time. I look forward to any questions. Thank you.
Madam Chair, ladies and gentlemen of the committee, my name is Sean Seifert. I was an Army Nurse Corps captain assigned to Walter Reed Army Medical Center. I completed my master's in nurse anesthesia at Georgetown University, and I've spent the last 22 years of practice in hospitals across Maryland, from Annapolis to Hagerstown, from Baltimore to Silver Spring. I've been the chief CRNA of many hospitals, including the system chief of a system of hospitals and surgery centers throughout Maryland and DC. So I have led and managed teams, including both CRNAs and AAs. From the systems level perspective, Maryland's current system already is the gold standard in anesthesia. We have care teams of physicians and CRNAs in the appropriate settings, and physician-only or CRNA-only care in others. This flexibility allows us to provide care in urban and rural settings and is a cost-effective strategy for Maryland patients. Adding AAs won't expand the workforce. It will only add more non-clinical physicians, increasing costs while not directly providing care to patients. With mandated direction ratios, AAs ensure that physicians are unavailable for direct patient care while relegated to a supervisor's role. If a physician is supervising 4 rooms and there's an emergency in 1, the other 3 rooms have to run independently now. CRNAs that have been educated and experienced to provide this care by directly collaborating with the surgeon have no trouble. AAs as mandated dependent providers are effectively prevented from starting the next case without the physician. This creates gridlock in the operating room, both inefficient and expensive. Collaborative practice models are the future. AAs will trap us in the past when Maryland needs to move forward. This year, Kansas voted against AA licensure. Ohio just removed physician supervision of CRNAs, and I believe CRNAs continue to be the right solution for Maryland. I ask for an unfavorable ruling on SB 951. I thank you for your time.
Good afternoon, everyone. Thank you very much for allowing me to testify today. Madam Chair, Vice Chair, and members of the committee, my name is Matthew D'Angelo, and I'm an Associate Lit Professor and Director of the Johns Hopkins University Nurse Anesthesia Program. Maryland maintains one of the most robust nurse anesthesia education infrastructures in the country. We house elite doctoral programs at Johns Hopkins, the Uniformed Services University, and the University of Maryland. Programs that consistently produce highly skilled, fully autonomous anesthesia providers who serve in every region of our state. And when the previous efforts to advance the anesthesiology assistant licensure were unsuccessful, Johns Hopkins stepped up and created its own nurse anesthesia program to help Maryland meet the needs for its anesthesia-like providers, creating a pipeline for our state. And this decision reflects a very clear reality. The marketplace, our clinical partners, and our state's needs all align behind the nurse anesthesia model. A central challenge to this discussion is clinical training. We don't have enough spots. How can adding another traineeship increase the number of surgeries? And it doesn't. Operating room training slots and preceptors are a finite resource. Every slot which is assigned to an AA student is a slot taken directly away from a doctorally prepared nurse anesthesia student. And when we redirect these scarce training opportunities towards dependent trainees, we reduce our ability to educate the nurse anesthesia workforce that Maryland relies on. Our priority must be to maximize the utility of the state. CRNAs practice throughout the state, serving in rural and underserved regions, and provide the greatest adaptability across all care settings. The AA model, by contrast, remains dependent, geographically constrained, and has not meaningfully scaled in clinical practice across all 50 states in over 60 years. That should say something. Investing Maryland's limited education and clinical resource into a workforce that cannot practice independently is strategically short-sighted. In closing, Maryland has the gold standard. It's CRNAs who are working with their MD colleagues. Thank you very much.
Good afternoon, Madam Chair, Vice Chair, and finance members. My name is Jacqueline Mitchell, and I am a certified registered nurse anesthetist with 18 years of clinical practice. I come before you in strong opposition of Senate Bill 951 from several professional perspectives. A retired Army colonel of 30 years, a military CRNA, clinical director an educator at the University of Maryland Nurse Anesthesia Program, where I educate and train students in the clinical arena, taking care of Maryland's sickest patients. The AA assistant care model is fundamentally flawed. And I would like to offer 4 reasons. First, it has failed to scale. The AA was first licensed in 1969, yet there are only about 4,000 practicing in the United States, and nearly half are concentrated in Florida and Georgia. The model has struggled to grow because it is entirely dependent on anesthesiologists for supervision. Second, Maryland faces a demographic cliff. Approximately 45.6% of anesthesiologists in Maryland are age 55 and older. It is fundamentally unsound policy to build a new workforce that is legally dependent on a provider group that is approaching retirement. Third, it is an economic dead end. This legislation diverts attention and resources from the workforce that already exists and is expanding, CRNAs. Nearly 6 decades, and the AA model has still failed to meaningfully scale nationwide. And fourth, it provides no solution to rural Maryland, because AA must be tethered to an anesthesiologist. They cannot practice in rural critical access hospital where independent CRNA already does. In closing, Maryland already has a gold standard of anesthesia care. CRNAs are filling the need today and will continue to do so. For this reason, I urge you to oppose Senate Bill 951. Thank you very much.
Thank you, Madam Chair, members of the committee. My name is Bill Kress. I'm here today on behalf of the Maryland Association of Nurse Anesthetists in opposition. I think you've heard some strong arguments on why this bill was rejected in 2009 and 2016. The good news is, because it was rejected in 2016, Johns Hopkins opened up a school, and they are now taking 35 nurse anesthetists every year into their program. We have the same at University of Maryland. Both of those schools, incidentally, get up to 1,000 applicants each. And so we have the ability to meet the needs. We have the ability to meet the access to care issue. If you were to pass this legislation, you would take up training spots. You would impact those school programs, and it would impact quality of care. I think you heard that the AA model is a failed model, and it's worth saying again, since 1969, they've only licensed 4,000 people, 2,000 in 2 separate states. The reason is they're dependent care providers. And again, to attach that to an aging workforce where anesthesiologists are 55 years old as a median age would make no sense. It would be a waste of resources for the Board of Physicians, who incidentally oppose this legislation, and it would just be in the wrong direction. Really, you were set up previously by the last 2 decisions of the General Assembly. We have the best model in the state, and we should continue on that pathway. In closing, I would just say MedChi also did not support this legislation, and I would urge this committee to vote unfavorably. I'll just leave it at that. Thank you, Madam Chair.
Thank you. Mr. Kress, you said MedChi did not support. They're not either way. There's nothing here for MedChi.
They were asked to support the bill. They were neutral.
They were neutral? Okay.
Yes.
I'd like to go back to, I think it was Ken, or maybe it's Matthew, that talked about the ratio, the federal ratio. Which one of you talked about the?
Yes.
Okay. Can you tell me about that ratio again, please?
So do you want me to discuss the difference between medical supervision and medical direction, or the ratio of 1 to 1, 1 to 4?
The 1 to 1, 1 to 2, whatever the federal government is requiring for Medicare.
Right. So the TEFRA rules, they're called the TEFRA rules, and there's 7 actual rules, is you have to, when you're under medical direction, because there is, again, the difference between medical supervision and medical direction. When you're under medical direction, an anesthesiologist has to be in the room with the CAA during critical times of an anesthetic, which would be, for every case, induction and emergence, meaning the start and the finish, And then during the case, any critical moment during the case, the anesthesiologist has to be in the room physically with the CAA to basically direct that CAA. That's why they call it medical direction. And Sean made the great point that when that happens, if they're at a 1-to-4 ratio, those other 3 rooms that anesthesiologist is directing suddenly become independent rooms. And that means that automatically they are now out of federal regulation for billing Medicare. And so, which is quite literally Medicare fraud in those other 3 rooms. Because during this one critical moment, especially when a day starts, so, you know, typical day at a hospital starts at 7:30. That's your start time for every single room. It's physically impossible for one directing anesthesiologist to be in all 4 of those rooms at the same time. That means 3 of those rooms are out of Medicare compliance, which is basically Medicare fraud. So that's when we go from 1-to-1, 1-to-2. If that model is the case, then 1-to-1 works, but that means you have to hire more anesthesiologists. That doesn't work financially. 1-to-2, according to that study, you're 33% out of compliance. And then when you get to 1-to-3, 99% out of compliance, because mainly in the start of the day, you are completely out of compliance because all of the cases start at the same time. So to be in compliance, you would have to stagger your starts, which quite frankly, that doesn't happen. So that would be the ratio problem.
When is medical direction required and when is medical supervision required?
Okay, so as far as the requirement is concerned, medical supervision is just how we bill Medicare. So the way I could describe the differences between the two is the aviation comparison. So let's put ourselves in a cockpit, and on the left seat is the person doing the anesthetic, and in the right seat is a couple scenarios. Okay, so let's say the right or the left seat, we have a CAA pilot. The directing anesthesia, so this is a medical direction. The medical director or the anesthesiologist pilot in the right seat gets in the cockpit and says, okay, we're gonna go to Albuquerque. I'm gonna tell you what speed to go down the runway. By the way, I'm gonna push the throttle. I'm gonna tell you when to pull back on the yoke. I'm gonna tell you what altitude to fly. I'm gonna tell you what heading, and then I'm gonna tell you when to land. They're gonna direct the anesthetic. Same scenario, but now we have a CRNA pilot in the left seat. The anesthesiologist comes in and says, fly me to Albuquerque. That's supervision, okay? Now, there's a CRNA scenario also that a CAA cannot be in, which is the supervisory, or no, I'm sorry, the collaborative model, which is in the state of Maryland. So CRNA pilot in the left seat, and let's say we have an aeronautical engineer in the right seat, meaning a highly trained individual, but doesn't necessarily know how to fly a plane. That's our surgeon. So the surgeon's now in the right seat. We're collaborating with them. And the surgeon says, hey, let's fly to Albuquerque. You're going to take control of this because I don't even know how to fly a plane. I have other knowledge. That's the collaborative model. The CAA cannot work in the collaborative model. So that's really the difference between supervision and direction. CAAs can only work under that medical direction, and that's why it's more expensive, because we have to have the anesthesiologists, and then that's where we start to get out of compliance when it becomes over 1-to-1, quite frankly.
Thank you. Senator Lamb?
Thank you, Madam Chair. I guess when it comes to there's been some talk about improving access for anesthesia services, right? And I guess just for my understanding, I think I asked some of this earlier to the other panel, do you have a sense of how many CRNAs are practicing in like more rural or underserved areas in the state?
I can tell you that back in 2008, we had 800 licensed CRNAs in the state. We currently have over 1,000. For the primary practice within the rural section of the states are CRNAs, right? So because the anesthesiologists are not going out to the rural areas. They're primarily located in the urban areas in the team care model.
So of the numbers that you gave, though, you didn't break that down.
That's because I don't have exact numbers in the rural area. But I can give you the general numbers. We've increased by 200 CRNAs in the last 10 years.
I can tell you, sir, that in the United States, CRNAs provide 75% of rural anesthetics. So If we break that down into Maryland, it's going to be a very high percentage.
Okay. That was both our questions, I guess. So we appreciate that. But, separate question, I guess. Do you not feel then that since there's such tremendous need, which I think we all recognize that there's, need for this, having CAAs, wouldn't there still be enough need to go around?
So I would question the assertion that there's a shortage. I've looked at the data. I can actually provide the data to you that we are above supply numbers, both for anesthesiologists and CRNAs. Now, going forward, when you have these anesthesiologists retiring because the median age is 55, you're going to have issues, and the issues should be solved by CRNAs who can practice autonomously. You can't get that through an AA. And so would an anesthesiologist assistant help us? Not in the long run, because they're taking away training spots. You're going to hurt the pipeline that we've created, and it was intentionally created to make sure that we have the best model in the best possible model in the state. So I would say they would not help. They would actually hurt access to care.
And if I may add as well, just look at the scale of the two professions. Looking at the CRNA community, it's 70,000 CRNAs nationally versus 4,000 CAAs. The idea that if we credential or license, AAs in the state of Maryland, that it's going to miraculously just fill the void is simply just not true. They graduated roughly, the last data that poll that I was able to find, 300 to at most 400 a year, versus 3,000 to 3,600 a year nationally for CRNAs. That is the proven pipeline. You also have two programs here in the state that are readily producing CRNAs, with other states supplying in around the region, the near region here. CRNAs are coming into the state. So the idea that this third provider type is just going to fill the gap is just simply not true. You've heard already this statistic that over half of them are just in Georgia and Florida.
Mr. Kress had brought up the training piece of this. Can you just give us a verbal side-by-side, like what the differences in training between CAAs and CRNAs currently are? Like time duration, location, competencies, anything that's just high level, like what are those differences there between CRNAs?
It's vastly different. So to be an AA, you can go to anesthesia school with any background, any undergraduate degree. You could be an art major. Take 2 years of anesthesia school, and then you're in the OR delivering anesthesia. For the nurse anesthetist, they have a 4-year degree in nursing. Then because it's so competitive, they usually have 3 to 5 years intensive care experience. That's prior to applying to anesthesia school. And then it's a 3-year school. And so you have this vast difference in clinical experience, right? And I think the important thing to know, and maybe no one said it today, because there is no cost savings with an AA. Their salary is identical to a nurse anesthetist, and they're billing at the same rate. So you get to trade quality of care for the same cost. And frankly, I think that's why this committee over the years has rejected this bill.
And I know on the sponsor panel, Children's National seems to be one of the proponents of this. Does Children's National have CRNAs, or are there any CRNAs at Children's? No. And that's because they're in DC, the arrangements are different and whatnot, I guess.
No, they just don't choose to.
They just choose not.
They choose not to use CRNAs.
And they choose not to train them.
Okay. Last question then. I know there are a lot of people in the audience, and when I step back, there's like a ton of people outside. Are the folks in the audience proponents or opponents? Opponents, okay.
I'm in support of the bill.
You said, good. I guess of the folks that are here, if you're a proponent, can you stand up? And if you're an opponent, can you stand up? Okay. All right. Thank you.
Thank you. Senator Guile?
Yeah, thank you, Madam Chair. I think Senator Lamb may have covered everything, but I actually do have a quick question. I just as a comment, I think oftentimes when we look at the scope of practice or I guess licensure type bills, a lot of times, I mean, I'm persuaded by if there's a demonstrated need, but when I'm looking also, like hearing some of this testimony and looking at what I see provided by the Board of Physicians, for example, I'm just not certain there's what the need is for this, one. And then second, but I'm curious because I do see in the Board of Physicians letter where they mention some other regulatory models used in states like Kentucky or Washington where certain anesthesia duties can be delegated to qualified professionals without requiring a new independent licensure category. Does anybody know what that's referring to?
Well, specifically for Kentucky, that's a physician assistant
Okay.
Licensure. Am I speaking correctly in that? And it's like a very, it's a very narrow prescribed definition or opportunity for this person. So it's heavily restricted. I just want to point out too, just some other states, California, New York, Kansas, the list goes on, have all rejected AA bills. These other opportunities that you're describing are just heavily restricted and narrow in scope.
Okay.
Senator, I can also speak to, in other states, there are certain ambulatory surgery center settings where physicians are delegating sedation to RNs, not advanced practice nurses, but RNs. And then we can start to get into the safety argument because these individuals have not ever been trained in doing anesthesia. They're following the physician's orders. I don't believe that exists here in Maryland. But I do know that it does exist in other states because of a training program that I was aware of that was teaching RNs how to do sedation because of that, because it was a safety issue. So that would be an example of delegatory authority, but then we have to have that safety argument.
Okay. All right.
I just want to make a comment if I possibly could. The senator, I'm sorry. The senator had brought up the Uniformed Services University and if there was a training program there because there was a question about a Navy commander who became a CAA or if something to that effect. There are no CAAs in the military. I've been a nurse anesthetist for 26 years. I've served in the Army for 33 plus years. I just retired. And I was a faculty member at the Uniformed Services University for almost 14 years. CAAs have to practice with an anesthesiologist. And when you're getting on board an aircraft or getting on board a helicopter, weight in cube matters, meaning the number of space and the amount of weight that gets on that helicopter matters. 2 people weigh a lot more than 1. CRNAs are the forward deployed anesthesia-led providers for our armed forces. And that is why CAAs cannot practice in those environments. And that's why the Uniformed Services University does not have that training program.
Okay. Thank you. Thank you very much for that. Thank you for your service. Thank you.
Thank you. Senator Ellis?
Thank you, Madam Chair. So we have a lot of stuff to get in, but I won't get into all of it. I'll just get into a bit of it. And you folks who were in the military, thank you for your service. I really appreciate it as a fellow veteran. So you never know where things will go until we listen. So let's talk. Mr. Kress, you said basically, what's the training required for CAs, certified nurse assistants?
For an AA to deliver anesthesia, they can have any 4-year degree. Then they do 2 years of anesthesia school, and then they're in the OR administering anesthesia. So no healthcare background, no clinical background.
No clinical. Yeah, okay. So I'm reading here, says for the CA certified anesthesiologist assistants requires a bachelor's degree with a pre-medical coursework, biology, chemistry, physics, calculus. So you initially said that they can be any major, but this saying they got to have the coursework followed by accredited 24 to 28-month master's in anesthesiology program. And so there are different levels, right? And so even, I know as having friends gone to Uniform University in Bethesda and gone to medical school from College Park, it was, and I think it's still, you could really have any major to go to medical school as long as you have the coursework. Is that
Yeah, I think the distinction is for a CRNA, they're a healthcare provider, they're a nurse. That is their training, that is their education, that's their clinical experience.
I understand that. It just seemed like you were disparaging the work that these people do to get to the point to teach. Or to treat
Look, not at all.
patients. Yeah.
It
seems that way. You're saying that they could just walk in there. Anybody could walk off the street and do it. But even for, like I said, for medical school, it seemed like individuals can have any majors as long as you have the coursework required for that school. So thank you for that. Sir, second from the left, what's your name?
Matthew.
Matthew. You talked about Medicare fraud because this certified anesthesiologist assistant can't bill Medicare. So, I mean, is that a rule written by Medicare?
Yes.
Or is it congressional law that?
These are CMS federal law. They're called the 7 TEFRA rules, and they are seven TEFRA rules. It is an act that was put in place to have, it's basically 7 steps to fulfill the requirements for billing Medicare under a medical direction model. And if you do not fulfill those 7 rules, then you are improperly billing Medicare. So in those rules, the directing physician, which would be the anesthesiologist, has to be in the room physically for all critical moments of the anesthetic, start, finish, and anything in the middle that is critical.
So, yeah, that's a rule. And basically, rules, regulations can change, and they often do, because here we pass bills for Medicaid to have new providers. I was a primary sponsor of a bill to authorize doulas to be able to be Medicaid certified. So we can't do that for Medicare at the state level, but the federal level can do that.
Certainly.
So it's basically, it's not really a experience or qualifications that will ban individuals from doing this. It's basically just a rule or a law change.
If that law change were to occur, we can have a different conversation, but that has not occurred yet. So for now, the 7 TEFRA rules are in place, and I think they've been in place since the early 80s, or maybe possibly late 70s, and they have not changed since. And if that law has changed, we certainly can have that conversation, but on the federal level, that would have to change, as you stated.
Right. Yeah, my point is basically, the gist was kind of like almost disparaging the kind of education these individuals go through to be a CAA, but I'm just kind of concerned that that approach is not really fair to folks who choose that line of profession. And for, say, the folks in Children's Hospital in DC who use those people, because I know having children who've gone and used those tremendous, professionally wonderful, top-rated services at Children's Hospital, I'm sure, and I know that for a fact, they would not put up with hiring anyone that is incapable of providing the very, 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 very best care to its patients. And thank you, Madam Chair.
Am I able to respectfully respond to you, or no? No? Okay.
Yes, sir.
It's fine.
All right.
It's late on a Friday.
All right.
We have
Thank you.
one more virtual unfavorable, Oriel Harris.
Yes, thank you, Chair. Good afternoon. My name is Oriel Harris. I am a health policy analyst with the Maryland Board of Physicians. The board respectfully opposes Senate Bill 951. While we value workforce expansion, this bill presents significant fiscal and regulatory blind spots that hinder safe implementation. Our opposition is centered on these factors, the first one being fiscal sustainability. With only 50 proposed licensees, this profession cannot be self-sustaining. To cover administrative costs alone, the board will be forced to charge these 50 individual practitioners exorbitantly high fees and inappropriately shift the burden onto physician licensure fees. Another factor in our opposition is market data. data from the DC Board of Medicine shows that licensing does not guarantee clinical activity, as only 49% of licensed assistants in DC actually provide patient care. With Maryland already at 97% adequacy in supply and demand for these practitioners, and also ranked number 4 in the nation for workforce density, there is limited evidence of a workforce gap for this profession. The board would need further discussions with the proponents to reconcile this density with the perceived workforce shortage. Another factor in our opposition is alternative models, which were mentioned in the panel. States like Kentucky and Washington successfully delegate anesthesia duties, although restrictive. This model protects the public without the administrative and fiscal impact of creating an entirely new regulated profession. The board is not opposed to further collaborative discussions with the proponents and stakeholders, and the board formally requests that this legislation not proceed during the current session. The board instead commits to a thorough evaluation in the interim, and we believe that through this evaluation, the board will be able to fulfill its mission to protect the public and assure quality care in Maryland. Thank you.
Thank you for your testimony. Do I have any questions for the representative from the Board of Physicians? No questions. Thank you very much.
Thank you, Madam Chair.
That ends the hearing, and it ends our hearings for the day and for the week. Thank you all for your testimony.